All right. Are you okay with getting started? Do you think it's all right if I get started with introducing you?
Yes. And can you hear me okay?
I can hear you loud and clear.
Okay, hang on, can you still hear me?
Yes, absolutely.
Okay, I think I don't even need these. Okay, perfect.
Great. Well, welcome everyone to Geriatric Medicine Grand Rounds. It's great to be here with all of you. We have a wonderful speaker today, Dr. Gwen Bernacki, who many of you, particularly those over at the VA, are familiar with. But Dr. Bernacki is an assistant professor in cardiology with the University of Washington, based over at the Seattle VA. But her focus for her research that she's done and for her career really surrounds a lot of things that are very important to us in geriatrics and palliative medicine. She is many of you might remember her from back when she did her internal medicine training here. Then she went to Duke and did cardiology fellowship, did a research fellowship there. And some of you might have worked with her when she did training with the Cambia Center of Excellence in their research fellowship, and then did work as an advanced fellow over at the VA. So she's extraordinarily well trained. And some of you might have heard her recently on a really excellent Jerry Powell podcast that she was able to talk about some of this work. So check it out if you haven't already. But thank you so much, Dr. Bernacki, for taking the time to talk to us today. And I'm really excited to hear more about your work.
Thanks, Dr. Bennett. I'm thrilled to be here. It was an honor to be asked to speak today. And thank you for the introduction. Let's see. Just trying to advance my slides here. I have no disclosures for this talk, other than as Dr. Bennett mentioned, I'm based at the Seattle VA here, and I work for Dr. Ritchie in patient priorities care, and I'm also a staff cardiologist here at the VA. A little bit about me: I'm a former hospital administrator. I did a graduate degree at the University of Michigan in Health Services Administration, and then later worked at Hopkins in the field before going on to medical school in my hometown of Buffalo, New York. As Dr. Bennett mentioned, then came to the University of Washington for my internal medicine training, and have now come back after cardiology training at Duke. So the objectives of this talk today are twofold. First, to address code status in the context of severe aortic stenosis. And then secondly, to highlight the utility of goals of care discussions in the context of aging, cardiovascular disease, including severe aortic stenosis, and multiple chronic conditions. So this cartoon was shared by one of my fellow cardiologists, Dr. Kirkpatrick, who is an author, the last author in our publication. And I think the caption here is quite appropriate. My advance directive was for you not to show up. So this sometimes I think is how we as cardiologists tend to approach the DNR topic and death. So first, a common question that I've received in relation to this topic of DNR and TAVR is, what is a TAVR? And is that the same as TAVI? Well, I took a moment last night to review up to date, and TAVR is the replacement and TAVI is the implantation. They are synonymous with one another. In my experience, TAVI was in the very early publications over a decade ago. And I think maybe it just didn't have the same ring as TAVR. And so in subsequent publications, I have always seen TAVR. What I think is important to note is that this procedure started now over a decade ago, And it was originally for patients who were non-operable, meaning they were not candidates to go to the operating room for having their chest cracked, going on bypass, and having a surgeon replace their aortic valve, largely due to their comorbid conditions, frailty, etc. This procedure was deemed very successful in the early stages, and so the population was expanded to the high risk group, and then subsequently the moderate risk group, and most recently within the last 2 to 3 years or so for all patients. So anyone with severe aortic stenosis of the calcific type can be considered for percutaneous aortic valve replacement. Of note, the valve itself has to be tri-leaflet, as you can see in this picture on the left. The procedure is not approved for those people who have congenital aortic stenosis due to a bicuspid aortic valve. And if you're looking for a little bit of a description, there's a 2-minute video that's put out by the manufacturer of one of these valves, and it's pretty straightforward and fairly neutral in terms of its language. I'm not going to show that today. Instead, I'm going to show you a device on fluoroscopy. This is a picture of one of these devices, and this was a publication showing what can happen with these. So you'll see this is the device, and every time I watch this, I get a little nervous. If you can see, it's starting to migrate. That should not happen in the cath lab, and there it goes. So this is a very rare complication of device deployment, and this was featured in one of the major cardiovascular journals. And I show this because I think we are all acutely aware that sometimes these procedures don't go as we planned. This in particular is a very rare outcome, which is part of the reason why this was featured in the journal. But I think more importantly, I wanted to share with you that this occurred in a 90-year-old. And so, this is, I think, a topic that is close to geriatricians and cardiologists' hearts. and just to let you know, for this particular patient, the device actually was retrieved, and he left the hospital actually without a replaced aortic valve, and did well subsequently. But that gets into, you know, when should these procedures be done, you know, and how should decisions be made about pursuing TAVR, particularly in light of the fact that we know that things can go wrong. So we were lucky enough to secure a small grant to explore this topic, and really what we set out to do was to ask questions about this. And the existing literature at the time, there was a publication by Dr. Coilwright looking at reasons that people choose to undergo TAVR. And this question was, what do you hope to accomplish by having your heart valve replaced? And more recently, she's gone on to publish and in a wider population, reasons that people are choosing to pursue this procedure. And you can see there's various clusters at this point for reasons that people approach this. But more than anything, I think what's notable is that people don't necessarily choose to do this procedure to prolong their life. That might be part of the story, but in a lot of cases, that's not the primary reason for patients choosing this procedure. So, in terms of do not resuscitate status and TAVR, there's really very little information. So at the time that we started this project, we really only had that study to show that potentially patients are choosing this procedure for reasons other than what was originally considered, which was in the non-operable population. There is no medical treatment for severe aortic stenosis. So those patients who were deemed inoperable were essentially hospice patients, not patients pursuing palliative care, but patients who were potentially near the end of their life. And so, of course, it's hard to know if it's a 6-month life expectancy, but it is a terminal illness nonetheless for which we have no medical therapy. So do not resuscitate. You probably don't need all of the references showing that DNR has been strongly associated with mortality. There was one paper in particular in JAGS, the Journal of American Geriatric Society, that was a propensity matched study that showed that risk of death was on the order of, on the magnitude of over 10% versus less than 1% in those without DNR status. There was also studies done using machine learning that showed similar findings. So, so when we designed this study, we really had in mind the ethical notion of autonomy. We didn't know exactly what we would find, but we did think about how asking patients to choose between maintaining a stated preference of DNR versus changing that preference to full code for what is deemed a quote necessary procedure could violate that principle of autonomy. So we were aware of this issue, potential issue from the start of this study. So our objective was really quite simple. It was to describe DNR code status policies and practices across TAVR programs and whether they align with patients' goals of care. And so by policy, we mean what are the formal institutional policies that are in writing. And by practice, we really mean, is there an informal way that a TAVR program is approaching code status that may or may not differ from the formal institutional policy. So we surveyed a total of 52 programs. We had a very good participation rate on the order of 70%. Between June and September of 2019, we conducted semi-structured interviews with TAVR coordinators, and we also looked at outcomes in the registry, the STS-TVT registry, which is really the primary source of outcomes data in this country for TAVR outcomes. And what we found was that 96% of programs, the vast majority of programs, addressed peri-procedural code status in some fashion. 1/4 of programs had established policies Some of those programs were able to share those policies with us, but only 2 programs out of the 52 programs had practices that actually reflected their institutional policies. And interestingly, those 2 policies that were shared that reflected practice were in opposition with one another. And so this is a busy slide, but it shows what we found. Which if you look at that first white box, you'll see that we actually excluded 2 programs because they were not conducting TAVRs in at the time of the survey. And then we did have 1 program that excluded patients from consideration if the patient was designated DNR. And then the vast majority, the 49 programs, considered patients, and then another 4 did not have a consistent practice. And we did have 3 of us, 3 cardiologists, review all of the transcripts and felt that in 4 instances, there was no consistent practice. So those were further excluded from consideration. 6 programs, on the other hand, did maintain DNR. And then the remaining programs, 39 programs, or a total of 78% here, temporarily rescind DNR. And within that category, we found that 7 programs required patients to remain full code for a minimum of 30 days after the procedure. 17 programs for the duration of hospitalization, and then finally approximately 15 programs, or 38%, required DNR full code status for the first 48 hours. And this is essentially a recapitulation of that. So, as part of these interviews, we looked at the comments that these coordinators provided about the rationale for these practices. And one coordinator who was part of the group that the group where patients were required to maintain at least 30 days of full code status, said if they're going to invest in it, they have to invest in it for 30 days for outcomes of the TVT and STS registries. This came as a bit of a surprise to us. This was not an anticipated finding, but nonetheless something that we heard on or read on multiple occasions. And here's a few more quotes. These are included in our manuscript if you're looking to get more of a sense of what people said in these interviews that reflect the practices. So TAVR is more of a way to improve quality of life than quantity. I mean, it's great that we get the quantity. And I think that's the way that a lot of our patients view it as well. But just because you don't want compressions or open heart surgery doesn't mean you're not open to having a procedure. Now this top quote here is part of a longer quote, but one coordinator summarized, "Why would you have TAVR if you did not want to survive?" So that program actually required a code status change. And so we looked for patterns to see if any programs or types of programs in particular required a code status change versus maintaining DNR code status. And as you can see in this figure, there was considerable variability in terms of program size, program location, urban, suburban, rural, or teaching versus non-teaching. We really could not discern any identifiable pattern as to why certain programs had certain practices versus others. Although I will say there were some programs that were located across from, let's say, assisted living facilities or skilled nursing facilities that had a more nuanced approach to code status. And so I do think there probably are some regional patterns, but not ones that we could identify through our data set. So, so essentially we saw no clinically substantial differences in code status practice. We looked at the registry. We looked at the STS-PROM risk score, which is the Society of Thoracic Surgeons predicted risk score of mortality, to see if those programs that addressed code status differently had let's say higher or lower STS risk scores. We did not see that to be the case. We also looked at rates of in-hospital cardiac arrest. Those are very rare outcomes, and they were rare in all categories. And then finally, we also looked at hospice disposition. And there's a very busy table that's included in the JAGS publication that shows the heterogeneity across groups in the registry. And so what we concluded was that there was overall substantial heterogeneity across programs, and that the time frame for reestablishing post-procedural code status was highly variable. And so I'm really eager to hear your feedback if you have any. But as part of our discussion, we really see this as being a call for standardization of DNR decisions before, during, and after TAVR to ensure consistent alignment with patients' health-related values. So I was very pleased to see that this paper on the multidisciplinary heart team was recently published earlier this month. I think we drafted this manuscript a minimum of 12 different times. This was a large collaboration of interventional cardiologists, cardiovascular imagers, non-invasive cardiologists like myself, who got together and really considered the various facets of the multidisciplinary heart team and what goes into the decision-making process for these structural heart interventions. And I'm very proud of this manuscript because of the collaboration that occurred to produce a summary as to the history of these heart teams. And I want to highlight by that big red arrow, that other. So thank you, geriatricians, palliative care clinicians, for being part of that extremely important other group and extended team, which is in that green box. Like I said, I haven't gotten a chance to fully review the figures and such as they were produced here. But one of the other figures as part of this publication shows how we're currently approaching these decisions. And Dr. Krishnaswamy and I really were very passionate about this topic and the importance of geriatricians and palliative care clinicians in the multidisciplinary heart team, that you are members of this team, whether you are physically there for that meeting or we are reaching out to you on a more individual basis. We see you as providing vital input about your patients That 90-year-old, there's, that I mentioned at the beginning of this talk, there's really no way that we can know about all of the aspects of important care that they receive, whether it's their cognitive status, their physical status. As you know, frailty is an independent risk factor for cardiovascular disease. We are not experts in frailty. And so we rely on you and your communication skills with patients and families for help making these decisions. And so it is really not infrequent that that I reach out to some of you now at the VA with questions about how to pursue these procedures, and really focusing on what matters most, and essentially understanding what the goals of care are in relation to this particular procedure. So I certainly am preaching to the choir here by sharing, goals of care discussions, but there's has been a lot of ways of referring to these discussions. And one definition that I saw was that these are considered overarching aims of medical care for a patient that are informed by the patient's underlying values and priorities, established within the existing clinical context, and used to guide decisions about the use or limitation on specific medical interventions. So I know sometimes we talk about advanced care planning, and I think it's always very important to be clear about whether or not we are referring to the documentation of advanced care planning or the discussion. I think certainly that is something that I learned conducting this research, that what is documented may in fact not reflect the true preferences or the current preferences of that individual patient, depending where you're looking and at what point in time you are looking at it. One thing that we did see or hear about and read in these transcripts is that there really is no practice for readdressing code status after TAVR. So I would certainly ask any person who's listening to this talk, whether you're a geriatrician or another clinician or a nurse or any member of the healthcare team, that after these procedures, that code status is readdressed and that a post form is updated, particularly because there may be a lot of ambiguity about code status thereafter. And we know that this is a very high risk population, and that the readmission rate is fairly high, and it may be for reasons outside of that TAVR. And so it's very important that we not neglect the patient's values, goals, priorities, preferences moving forward. So overall, I think the growth of the aging population has coincided with the increasing availability of complex procedures. I think the TAVR procedure is a very nice one to discuss because it's been in use for over a decade, and there was a very scripted approach and a very well-researched means by which this procedure was brought into commercial use in this very high-risk population. And it was also very carefully studied in terms of the degree of underlying anatomic risk with the inoperable patients first being eligible for this procedure. But mitral valve procedures, MitraClips, and there's a variety of different mitral valve percutaneous procedures that are on the horizon, in addition to tricuspid valve procedures, where I think these issues may become even more complex, and it's going to be increasingly important for us to have these important collaborations so that we can determine whether or not they are appropriate in an individual patient. Older adults who are often frail with multimorbidity have further increased procedural risk and complexity. And I think that's something we need to keep in mind for the future, especially in the context of cognitive impairment, where we may not be able to discern directly from the patients as their dementia may progress. So with that, I'd like to acknowledge a whole team of people. Of course, I have Dr. Ritchie and Dr. O'Hare listed. They've helped me with numerous projects and fielded my ideas on this topic on multiple occasions, as well as the team that co-authored the manuscript that's in JAGS. And I have here the link for the Jerry Pal that with Dr. Krishnaswamy. And then finally, I have the QR code, and I'll come back to this, but and just a picture of my twins. I'd be remiss not to acknowledge that they were born at the University of Washington, spent a very short period of time in the NICU, and I've got this really fantastic soccer card that went missing last night. And so it gave me a long pause about what it takes to collaborate. This card belonged to one twin and was brought to school by the other twin. And so it made me think about risks that you take and what happens if you lose something valuable, and how important that communication is between one another. So with that, I want to make sure that I leave enough time for questions. I think there tends to be lots of lively debate about this topic. It was controversial from the start, and I don't see that as changing in the short term.
Thank you so much for that presentation. And we do have some questions that popped up in the chat. I'm going to go first to Wayne, who has his virtual hand up. He has a question.
Oh, hey, thanks, Gwen, for presenting this. Quick comment and then a couple of questions for you. You know, here at Harborview, our unique environment here, the question of perioperative assessment of either critical or severe aortic stenosis in emergent situations. It's pretty, every month or two we get a call at 4 o'clock in the morning from a resident who's trying to pre-op a patient who's been flown in from a cruise ship from the inside passage, having just broken their hip. So a 91-year-old with a femoral neck fracture, who it turns out has, severe aortic stenosis, and there's no time for a TAVR. The ortho team wants to take them first case, 7:30 a.m. I'm struck that maybe general anesthesia is far more sophisticated and developed than we actually realize, because often those patients just go to surgery and it turns out okay somehow. The other interesting thing at Harborview is our surgeons, orthopedic and general surgeons, have become very comfortable with people being DNR. And they just tell them during informed consent, hey, while you're in the surgery intraoperatively, if something happens and we need to do a little resuscitation, you'll be intubated already, and we'll just take care of it. And then they just make a judgment call. They don't bother changing code status. If somebody goes into asystole, they, oh, okay, well, that's it. But if they have some sustained VT, and say, well, we just shock them and carry on with the hip surgery, which goes remarkably quickly as well. So I wondered about your opinion about, is general anesthesia much safer, and can we feel a little more comfortable sending patients to surgery with severe aortic stenosis? Because it takes a few days to get a TAVR done, right? I mean, from consideration to actually getting it done, that's not a very emergent thing. And my final question is, are there actually any living buffalo in Buffalo, New York?
I'll start there. I'm a number 3 Hamlin. I'm part of the Bills Mafia. I have followed Damar Hamlin's recovery quite closely. There are a lot of Buffalo statues in Buffalo, New York, but no actual Buffalo. That said, I think you asked about 12 questions there, which I love because I think it illustrates just how many issues can occur simultaneously and the speed for which we need to make decisions and the smoothness that we need these teams to be able to function, to be able to produce a desired outcome for a patient. And so I think first and foremost, the scenario that you presented as a resident, I very much remember these cruise ship scenarios. And a lot of times, in my limited experience, those cruise ships are sort of bucket list items, and those were goals for those patients, right? And the idea that something bad happened on that trip was maybe not all that unexpected. But then the question is, what now, right? And so I think in the Jerry Pale podcast, I think we briefly touch on this, but symptomatic severe aortic stenosis is still a different entity than asymptomatic severe aortic stenosis. I do have some geriatric patients in our practice. I say my practice that I'm co-managing with geriatricians who have severe aortic stenosis, but for all intents and purposes are not having any symptoms related to that. So this procedure is intended for patients who are having symptoms, and typical symptoms, and this is where it gets tricky. Typical symptoms can be syncope, and that's largely due to decreased cardiac output in the setting of a stenosed valve. Can be due to heart failure, so the pump starts to fail in the setting of a stenosed valve, or it can be anginal symptoms, right? That the patient starts experiencing chest discomfort in the setting of this stenosed failing valve. So we now have some data to suggest that patients who have asymptomatic, very severe aortic stenosis may benefit from intervention. And by that, that's typically velocity of 4.5 meters per second squared as opposed to 4. But the bottom line is, when a patient is having symptoms, particularly a geriatric patient, especially the veterans I've met, sometimes it's hard to determine whether or not somebody's having symptoms or they're just adapting as they go. Well, I used to go get the mail, but now my grandson brings it to me. Well, what's the reason for that, right? I mean, people are remarkably adaptable. I mean, right? We had this pandemic and we all sort of made workarounds. And so getting a really good history in these patients is exceedingly important, because if people are having symptoms, that's when it becomes more dangerous. And the classic Braunwald outcomes, there's a next time I'll make sure I include it in the talk. There's life expectancy. When somebody has syncope in the setting of aortic stenosis, that's very concerning, and more so even than anginal symptoms, let's say. But the case that you bring up is the emergent surgery. So for patients who are really symptomatic from their aortic stenosis, if they go to the cath lab, that's actually considered a different category of TAVR, and the way that the program's outcomes are monitored for those patients is a bit different than an elective TAVR or even an inpatient TAVR. And the way that code status is addressed in those situations by some programs is a bit different. We didn't include that in the publication, in part because it's not very straightforward as to how code status is addressed by particular programs. But here, the scenario that you described, for all intents and purposes, that patient may have had asymptomatic severe aortic stenosis. And so for these patients to do well in the operating room with a trained cardiac anesthesiologist with expertise, in monitoring doesn't surprise me terribly. Actually, I in some ways think that might be expected. When these percutaneous procedures were done at first, they were done with general anesthesia, and now a lot of times they're done with conscious sedation. Geriatric anesthesia is a very active area of research currently. And I think there's something to be said about cognitive impairment and delirium in particular, and that we need to be mindful how we approach doing these procedures, whether in the cath lab or in the operating room. In terms of how we approach code status, I think the surgeons actually are a step ahead of us. The Geriatric Surgery Standards Verification Program, I think I have the title of that a little garbled, but I did almost include a link for that. And there is a link on the GeriPal website with our podcast linking to those standards. And essentially, they have learned from our colleagues in anesthesia. Not surprisingly, the approach to code status really started with the anesthesiologists. And essentially, there's two approaches. You can either choose, the patient can either choose, this is what I want you to do, and be very directive. I want you to either resuscitate me or don't resuscitate me, and I want you to do it categorically, this way. But the alternative approach is essentially to leave it to the discretion of the anesthesiologist. And I'll be upfront and say that I think having spent time in the cath lab during my training, I think that approach makes a lot more sense to me, because it is very difficult to anticipate exactly what will happen in the cath lab. And that's why I showed that one video. I have never seen a valve migrate that way, and it is rare. But what we're talking about is rare outcomes. And when we look at the registry, the incidence of cardiac arrest is quite low. It was on the order of a handful in our population. So I think that the approach to code status that you described, Dr. McCormick, was one, it sounded like informed assent for what was, a procedure that needed to be done urgently, if not almost emergently. I wouldn't, they needed to be done in very rapid fashion. So I think, the literature from Dr. Curtis on informed assent and the circumstances for which you would choose that approach, it seems quite logical. I will say, having conducted, I was actually the one that did these interviews for this study. The way that program coordinators describe the process of coding, cardiologists, I think, conceptualize a code in somewhat of a unique way, in that we all learn ACLS, right? But what happens in the cath lab, I know as a trainee, if you poke the RV when you're trying to get a biopsy, you might see some ventricular arrhythmia on the monitor. Like it's really, as a non-invasive cardiologist, I can say it's pretty easy to do. And so, the way that some of these program coordinators would describe, approach to code status, some of them actually, have a menu like, okay, inotropes, yes, shock, no. I think that slice and dice approach of talking to patients is it's sophisticated, but I think it's also I think there are risks to that, because we know how hard it is to communicate with patients about various procedures. So trying to get into potential scenarios in the cath lab with somewhat of a selective approach to coding, I think that's something that we collectively should have more of a discussion about as to the appropriateness of that, and potentially rely more on our colleagues in anesthesia and in surgery, because they've certainly considered this and have formalized documents for addressing DNR code status, which right now we as cardiologists do not have. So that was a really long answer to many of those questions, I think, that you've asked. But in short, I'm not surprised that those patients had a smooth surgery and recovery, and it doesn't strike me as inappropriate to pursue an informed assent approach for some of these patients who may have asymptomatic severe aortic stenosis and a clear indication to go for surgery.
Thanks.
Thanks so much. There were a couple other questions. One was probably pretty straightforward. If you happen to know if there were differences in DNR changes that you looked at in your study related to whether or not the hospital had a religious affiliation.
That is a wonderful question. We did not stratify that way. And these were semi-structured interviews. And like I said, I was the interviewer for all of these interviews, which has pluses and minuses, right? Because the first interview obviously is going to be different than the last interview, because I'm working from a body of knowledge at the time of the last interview. In my recollection, it did not come up about religious affiliation in any of these interviews. They're semi-structured interviews. I'm trained from Dr. Helene Starks in qualitative interviewing. And one of the advantages of doing a qualitative study in an area where there's very little pre-existing data is that it gives you the flexibility to explore topics as they arise. And had I heard that on several occasions, much like I heard about the parsed approach to addressing code status in the cath lab, I think I likely may have asked some questions about it at least, but certainly had I thought of that going into the interviews, it might have been something that could have been worked into the interview guide. And certainly an interesting question for future research.
Great, thank you. And one thing we think about a lot in general, but also with TAVR, is any potential effects on cognition with the procedure. And there was a question about if we have information about patients with cognition before and after TAVR, if you want to comment on that.
Sure, there actually is a fairly recent publication about cognition and TAVR. And I haven't had the opportunity to review it closely, but I think it was largely positive findings, meaning that TAVR can be a useful procedure for patients who have cognitive impairment. That said, I think the severity of the cognitive impairment / dementia, right, is of critical importance. not only that, but I think the type of dementia is very important. So anecdotally, many of the TAVR coordinators commented on improved cognitive function. I think that was likely in patients who had low cardiac output in the setting of a stenosed valve. I think as clinicians, probably one of the most important things to consider if the decision has been made to pursue a valve replacement in the setting of cognitive impairment is the potential for delirium, and that post-procedurally, these patients have a deliriogenic protocol in place while hospitalized. I think the question of whether or not you pursue a TAVR is in a patient with cognitive impairment or delirium is going to become an increasingly important one, and one that I have encountered clinically. And I'm very interested in pursuing further research in that area. And like I said, I can, Dr. Bennett, I can provide you with the link to that most recent study. I think it was published just a year or two ago in JAGS. That's the one that I think that's been most comprehensive to date.
Great, thanks so much. I don't know if Dr. Vig is able to unmute. If not, I'm happy to share the comment for discussion.
So I'm outside walking in, so it's kind of loud. So if you want to just read it, that'd be great.
Oh, great, can do that. So Dr. Vig brought up an important point. We want to honor the patient's preferences, but there also is a level of clinician comfort and some distress that can come with, doing a procedure that could cause a fatal arrhythmia and someone who's DNR and not being able to do something about that. So there are some clinicians who might not be comfortable with that scenario. And so her comment, includes making sure that there's an ability for those who are uncomfortable with that scenario to opt out because of the potential, trauma that a clinician could experience if that's something they're not comfortable with going in.
Right. I'm so glad, Dr. Vig, that you mentioned this, because really the crux of this paper is, and Dr. Starks reminded me of this multiple times, it's that feeling in your gut. And I think that's why this paper has generated a lot of interest, and far more than I ever anticipated. It's because of that moral distress, right? Are we doing the right thing? And what is it like? What is it like when things go wrong and you feel like your hands are tied, right? So I had program coordinators describe fatalities in the cath lab where DNR was maintained. They did it in a fashion, by which private patient information was not shared. But essentially, the first question that I asked, which was not part of the script, but part of the semi-structured interview was, what was the Monday morning quarterbacking on that, right? Because we all have M&M conference, and I wanted to know sort of broadly, when these circumstances occur, is there any regret? And interestingly, I was very surprised to learn that from these TAVR coordinators who described broadly these scenarios where this does occur, that is the approach of their program, and it's built right into their practice, and it's something that they have tacitly agreed is how they're going to address these circumstances. And I think that's where these broader conversations become increasingly important. That, potentially there could be an approach that there are some programs that are designated, programs where, this will be the practice, or that there'll be particular operators that are comfortable with this type of practice style. I'm not sure exactly what that would look like, but all we can do is look to the surgical literature on buy-in. And so this has been an issue for as long as I think surgery has been occurring, that we have certain expectations for how people will behave. You know, how will the family respond if something happens, and what is the expectation for which I will act in the operating room, and do I have the liberty to do what I feel is most comfortable to me for whatever reason, whether it's technical reason or that, you know, way to diminish the moral distress that's associated with what's occurring. So I think I'm not an ethicist, certainly, and I don't have answers to this other than to say that I think this is an extremely important topic, and I think sometimes is not addressed up front, and sometimes in these consultations that can be really buried, but present. And I think drawing attention to it, I'm glad you did that, Dr. Vick. Thank you.
Great. Well, I think we're getting close to 9 o'clock, and I really appreciate your presentation and all the time you took to answer these questions. And I thank everyone who added to the discussion and brought up some really great questions. I think there's a lot more to talk about, but for now, I think we will wrap up, and we're very appreciative that you took this time with us today.
Sure. My email address is just my last name at uw.edu. For whatever reason, I'm at the VA today, and how I set it up, I couldn't see what was coming through the chat. So if there are other questions, please feel free to reach out to me. It was really an honor to be asked to talk today. And thank you for the excellent questions. It always gets me thinking.
Great, thanks. Well, have a great weekend, everyone.